sorry for being late. Uh, so today I'm going to take you through about lever. So the objective of this session, so at the end of this session, you are supposed to define what is lever, and you are supposed to know or understand the physiological preparations of lever, and you have to understand also the different stages of lever and its management and modalities of lever induction and how are we going to terminate pregnancy. So those are the objectives of today's session. So when you say labor, it is characterized by a forceful and painful uterine contraction that ultimately leads to dilation of the cervix and causes descendment of the fetus to the birth canal. So mostly, this is the last few hours of human pregnancy. When you say delivery, it is the mode of explosion of the fetus and the placenta. Okay, then when does a normal labor start? So usually, or what causes labor to start is not known, but it usually starts within 2 weeks before or after the estimated date of delivery. So that is the most common onset of labor. So on average, labor can last like 12 to 18 hours in a woman of first pregnancy. So that is the most common occurrence, and usually on subsequent pregnancies, it is usually very shorter, like 6 to 8 hours. So most of the time, there is a blood show. So there is a small amount of blood, like tingled with the mucous membrane or discharge. It actually appear in the genital area. So most of the time, this blood show usually precedes the onset of labor by as much as 72 hours. So what are some of the changes that can happen during labor, or what are the physiological changes that can happen before the onset of the true labor? So the most common physiological changes are lightening and contraction. So lightening stands for the settling of the fetal head into the pelvic organ and usually occur most of the time 2 or more weeks before the onset of the true labor in the first pregnancy, and also it usually happen in a woman who is actually having a previous delivery. Lightening often does not occur even until the early stage of labor, but in the first time, if it happened on the first pregnancy, like in the primigravida, it usually occur like 2 weeks before the actual labor starters. So as a result of the lightening, like the mother actually feel discomfort in the pelvic areas, and there is a possibility of frequent urination. And then the next step or the next physiological change that can happen is the contraction. So this Braxton Hicks contraction is the false contraction. Is usually irregular and painless uterine contraction, and it is usually occur slowly with increasing frequency toward the last weeks of pregnancy. So most of the time, it occurs during the last 4 to 8 weeks of gestation or pregnancy. However, it may occur more frequently, sometimes even like every 10 to 20 minutes, with a greater intensity during the last weeks of pregnancy. So this contraction is usually starts to increase the frequency, usually continue towards the end of gestation period. So in general, during the course of several days to several weeks before the onset of labor, now the cervix will begin to soften, efface, and dilate. Those are the common changes. So as a result, in majority of the cases, when the labor starts, the cervix is already dilated like 1 to 3 centimeter in diameter. So those are the major changes we are going to see during labor. So like when the true labor starts, like the cervix is already dilated. So this dilation is as a result of the physiological preparation that can happen before the onset of the true labor. So what are the criteria to consider normal delivery? So if there is a spontaneous explosion of the fetus, if it is a single fetus, if it is mature, the probability of having normal delivery is very common. Then presentation by vertex. This is like the head comes first in the pelvic areas or to the birth canal. So vertex presentation is actually possible. However, if the presentation is actually not on the vertex position, it sometimes can come to the sideways. Sometimes even the shoulder comes first. So sometimes when the product comes first, so that presentation will allow to do normal delivery. And within a reasonable time, sometimes if the liver is actually longer beyond the recommended time, we are supposed to induce delivery. We are supposed to consider cesarean section because normal delivery might not be possible. And apart from that, those conditions should not have complication to the mother and to the fetus. So this is the role of the gynecologist and the midwife to check whether that labor will not cause any life-threatening condition for both parties. So what are the influencing factors of labor? What really causes the progression of labor? The first thing is the power of the uterus. So how is the contraction? Were there any significant contraction to the innermost layer of the uterus? We call it the myometrium. Was there any significant power? So most of the time, what causes contraction of the uterus is the force which was applied by the mother, and apart from that, the uterus, oxytocin. Remember, oxytocin is the posterior pituitary hormone that is secreted from the hypothalamus and is stored in the posterior pituitary, but it will act on the uterus. So usually the concentration usually reaches to the peak point during labor, which is very important for contraction. So the next parameter or the next P is the passenger. How was the presentation of the passenger? That is the fetus. With this normal presentation, we call it like the vertex presentation. That means like when the fetus of the head comes first, that is normal presentation. Then third one is the passage. How is the pelvis of the mother? Was it really adequate to allow the passage of that fetus? Sometimes there is a possibility of a disproportion of the pelvic areas, like the fetus size will not allow the passage in the pelvic organ. So because of that reason, there is a possibility of fetal distress and death during labor. So even that one requires cesarean section. So you can actually even see there are several conditions that are supposed to be fulfilled before before we expect normal delivery. Then having said this much, let's see about the different stages of labor. So what are the different stages? The first one is known as the first stage. It usually starts from the onset of the true labor contraction and ends when the cervix is fully dilated. Normally, when do we say the cervix is fully dilated? It is supposed to be widened for a minimum of 10 centimeter. So this is the longest stage of labor. Have you seen this is the normal presentation like during labor? So we're expecting this presentation. But if this side comes first, the probability of normal delivery is very unlikely. Sometimes even this part will come first. This actually can even come first. The probability of like spontaneous delivery is very unlikely. So this one requires even a cesarean section. So there are two phases in the first stage of labor. Like the early phase, we call it the latent phase. The second one is active phase. So the latent phase starts from the onset of labor until the cervix dilates for 3 centimeters and usually lasts for 8 hours and below. So at this point, what will happen? There is a contraction of the metrium twice every 10 minutes, which lasts for about 20 seconds. So remember, for every periodic contraction, the mother is actually feeling the pain. So that is really very painful because of the contraction. Then when you say active phase, this is actually from 3 centimeter until the cervix is fully dilated. So this one, at this point, like the frequency of contraction is usually 3 times every 10 minutes, and it reaches like 40 seconds. Sorry, it lasts for above 40 seconds, which is even longer. So you can actually even see at the stage of labor increases, the frequency of uterine contraction usually increases. So at this point, we have to encourage the mother to apply force for possible uterine contraction. Then the second stage of labor is very short and usually begins with complete dilation of the cervix and ends when there is birth of the baby. So it ends with the spontaneous delivery of the baby. And most of the time, especially in a multigravida woman, the duration lasts for 30 minutes to 90 minutes. Yeah? In multigravida human, it is usually very short, but in the primigravida human, it usually lasts up to even 3 hours. So this is in ways shorter, so we expect delivery of the baby until this period. So this is actually how you can see. Sometimes even have to pull. If they give the head, they can actually even pull the head of the fetus to aid delivery. Then the third stage of labor is when there is a separation and explosion of the placenta and from the uterine wall. So as you can see from the diagram. So this one is very short, but it can last even up to 30 minutes, and it is the shortest stage of labor. So in the third stage of labor, when the membrane is separated from or when the placenta is separated from the innermost membrane of the outermost membrane of the uterine layer, what will happen? There is a possibility of bleeding. So the fourth stage labor is normally the period after the explosion of the placenta. So it usually lasts for 2 hours and the risk of bleeding is usually very, very high. So at this point, appropriate care is very important. Otherwise, there is high probability of postpartum hemorrhage and ultimately causes death due to hypovolemic shock secondary to excessive bleeding. So if you can see actually, the most common days of maternal days is usually postpartum bleeding. So what are the physiological changes or the physiological effects of labor? So in the first stage, the effect is very minimal to the mother. For the fetus, due to the transition and movement, there is a possibility of like molding of the fetus in terms of shape. In second stage, because there is a continuous contraction, now the mother can have increase in blood pressure, in systolic blood pressure, as well as there is a possibility of minor injuries to the birth canal. So as a result of like the force, there is a possibility of minor injuries. On the third stage, there is a possibility of blood loss or bleeding as a result of the laceration or when there is actually like delivery of the placenta, there is a possible bleeding. So those are some of the physiological changes we're expecting during labor. So having said this much, about the stages of labor, how do we manage labor? So the goal of therapy is like safe delivery to the mother and to the fetus. That is the most important goals of the management. So most of the management in different stages of labor is usually supportive therapy. You just give supportive therapy as much as you can. So you have to give adequate care and encouragement so that the mother will actually have, that is the psychological component, then the mother will be reassured during this painful stage of labor. So in the first stage, how do we manage first stage of labor? Remember, most of the management is usually like the procedure. So we request for the mother to ambulate. So the mother, when they're in the first stage of labor, they are supposed to ambulate. So most of the time, lying in the supine position will affect like contraction of the uterus. So is usually not advisable. So I don't know whether you have noticed. Most of the time, you will see when the mother is in the first stage of labor, the physician order normally them to like walk around like within the vicinity of the ward or delivery room. So ambulation is very important. Then apart from that, when someone is in active labor, they're supposed to avoid ingestion of solid food. So in principle, like solid food items are generally not recommended because of the possibility of aspiration of the content to the respiratory tract and even can cause even vomiting. So because of that reason, what they normally do when the mother is actually getting like, or when the mother is getting weak, or as a result of like depletion of energy secondary to the force of contraction, now they are supposed to give intravenous administration of glucose. So normally, according to the current evidence, according to the current evidence of randomized control trial, there is no harm of taking like solid food item during labor, but generally is not recommended because in most of the physician will not allow to take food during this time. So to prevent dehydration, maybe they can take clear liquids. Ice chips are usually recommended to moisten the mouth and the lip from getting dryness. Then, in the first stage, when a significant amount of fluid and calories are requested, now that is when they are going to give intravenous fluid as well as dextrose. So because of long labor, the mother can be dehydrated. The mother will actually even lose significant amount of calories and they're supposed to replace. Then you have to monitor the pulse and the blood pressure of the the mother every 2 to 4 hours. That is the recommendation. Sometimes even more frequent as depending on the mother condition. Then you have to check the fluid balance, like don't dehydrate the mother and don't even overhydrate the mother. So after delivery, I don't know whether you notice the mother puffy face is usually very common. This is because of the fluid replacement. Then the second stage is when we are expecting delivery of the baby. So the mother usually feels a desire to bear down with each contraction. So that is expectation. So we have to as I mentioned before, it can be longer with primigravida and it can be even shorter in multigravida woman. So depending on the pushing effort of the mother, the quality of the uterine contraction and the type of analgesia used, there is a possibility of change. But generally speaking, it is not advisable to give analgesia during labor because it can affect the energy of the mother to push down to deliver the fetus. So generally, they don't give anesthesia during normal labor unless the mother is doing. If the mother is actually doing cesarean section, they can do what they can consider to give like spinal anesthesia during cesarean section. So in second stage, apart from fluid replacement and administration of dextrose intravenously, you have to give encouragement and support. That is very, very important. So you encourage the mother and you support her and support her to do active pushing. That is very, very important. Then, of course, you are supposed to listen like every 5 minutes to the fetal heart in between contraction to detect any bradycardia, and you check like the pulse and the BP regularly. That is the recommendation. Specifically when there is a pre-existing condition, you have to monitor properly. Then apart from that, now if there is a possibility of risk of tear, now consider episiotomy. So this is only considered where there is a possibility of tear. So episiotomy is minor incision between the genital areas and the anus, so that you just do they will do minor incision, then you will actually like allow or widen the genital areas to pass or delivery of the fetus. Then apart from that, if the contraction is if not frequent, maybe you can augment with oxytocin. So oxytocin is a synthetic hormone that can be administered intravenously, and most of the time within 0.5 to 1 milli international unit per minute. So it can be actually gradually increased depending on the contraction. So if the frequency of the contraction is not adequate in second stage, maybe then you need to consider uh, uh, administration of oxytocin to increase contractility. So those are the management strategies we need to consider. But in third stage, the third stage is where the placenta will be delivered. So in this stage, you have to inspect the genital area for any laceration, then you will do surgical repair accordingly. Then what we need to be very careful about in the third stage of labor is there is a possibility of bleeding because of delivery of the placenta. So separation of the placenta generally occur within a few period of time. Sometimes it may take like 30 minutes to spontaneously separate. So how do we know when there is a placental separation? You will see a fresh blood in the vaginal areas. Then you will see like umbilical cord lengthen outside the vaginal areas and etc. So those are some of the things that can indicate us the placenta is delivered. Then, after delivery of the placenta, attention will be given to prevent excessive postpartum bleeding. So, most of the time, after delivery, we are supposed to consider like oxytocin administration to prevent, also to prevent as well as to treat postpartum bleeding. So most of the time, a diluted solution of oxytocin is usually recommended. Okay, so in the third stage of labor, that is the most important thing apart from inspection. So this is how we are managing labor. So more of is the role of like the medical team, like the midwives, the nurses, and the gynecologists, and our role is just very minimal in the labor ward. So, but we'll focus more on about the pharmacological aspect of the management. So we have to like give proper instruction what dose of oxytocin they are supposed to given to the mother, and or how much, like how can they actually dilute. So those are some of the rules we are supposed to know as a pharmacist. Then apart from that, sometimes we have to induce and augment labor. Augmentation is like artificial stimulation of labor that has begun spontaneously, and by mentioned most of the time oxytocin is usually used in augmentation. Then sometimes when the liver is actually delayed, like after like the maximum term is or gestation period is 42 weeks from the last menstrual period. So at 42 weeks, if the liver is not able to come, now they are supposed to induce. So induction is the process of initiating labor by artificial means. So what are those artificial means? We shall discuss in the next few slides. So what are the common indications of induction of labor? So if the mother condition and the maternal conditions will determine whether to use to induce or not. For example, if the maternal condition, like in case of preeclampsia, DM, heart disease, we have to induce. And also if the pregnancy is actually prolonged, like beyond the term, if there is RH incompatibility, we call it retinoblastosis fetalis. This is incompatibility between the fetal blood and the maternal blood, and ultimately causes hemolysis of the fetus. Is very common. So in that condition, we have to induce. But there are also contraindications for induction of labor. For example, if the pelvis is contracted despite we induce, but not able to achieve normal delivery. Placenta previa. Sometimes the placenta actually even can block the cervix. So that is, we call it placenta previa. So in that condition, there is no possibility to induce labor. Then apart from that, if the mother is actually having previous cesarean section, is very likely to achieve normal delivery. By the way, according to some evidence, it is possible to have normal delivery after doing after cesarean section, but most of the physicians will not recommend to have normal delivery because of the fear of complication after the first cesarean section. So if you have done cesarean section in the first birth, now the subsequent birth will be like cesarean section. So this one is pretty much or easier. I think even I encourage like all the mother, instead of actually having the suffer doing labor, to do the cesarean section. But I think this time around there is an option, but most of the physician will consider when there is a real indication of cesarean section. Then how do we induce labor? Were there any pharmacological modalities we can induce labor? Yes. So the first step is ripening of the cervix. How do we ripen? Ripen is actually like involves softening and thinning of the cervix. And this is the first step in inducing labor. And most of the time, prostaglandin class of drugs are the ones which are very important for ripening of the cervix. So they are very natural hormone. Prostaglandins are natural occurring hormone that stimulates the ripening of the cervix. So after the cervix is undergo like softening and thinning, now the next step is using oxytocin to promote contractility. But anyways, those are the prostaglandin analogs that can be used for ripening of the cervix. And most of them are usually given intravaginal tablets. So I think this one is widely available. Misoprostol, Cytotec is usually the most commonly used class of drugs to ripen the cervix. Then after that, after ripening of the cervix, the next step is administration of intravenous oxytocin. By the way, oxytocin is not given orally. If given orally, it is a polypeptide. It can be distracted immediately from the GIT tract, so has to be given via the route of administration. IV, IM, I think also it can be given subcutaneous in intranasally, but IV and IM is the most common route of administration. So this is the dose anyways, 0.5 to 1 milli unit per minute. This is the most common dose that can be considered for during labor, 0.5 to 1 milli unit per minute. So for induction, start with prostaglandin, then continue with oxytocin. Okay, this is how you are going to induce in case of prolonged labor. Then the next step is how do we prevent postpartum bleeding? Remember, when you say postpartum hemorrhage, it is defined as a loss of more than 500 ml of blood after delivery, that is normal, and like 1 liter from cesarean delivery. So this is one of the leading cause of maternal deaths globally and accounting for like at least for 25% of maternal disease. You can actually even imagine, even in our setting too, the most common days after delivery or during delivery is the bleeding. So ultimately, the patient will actually develop anemia, hypovolemic shock, and ultimately death if immediate intervention has not been done. Then what causes postpartum hemorrhage? In case of prolonged third stage of labor, if the mother is having multiple delivery, if they have done any episiotomy, maybe in case of fetal macrosomia, it can cause damage in the local areas, and in history of postpartum hemorrhage, those are some of the possible risk factors. But the possible causes is usually atony of the uterus and any trauma which ranges from laceration, hematoma, or any inversion or rupture, or any problem, any retained tissue, and invasive placenta. Sometimes there is actually a strong like connection of the placenta with the uterus. So that is very invasive. So during delivery of the placenta, there is a possibility of rupture of the blood vessel and ultimately causes significant bleeding. So those are some of the causes. If so, at the pharmacies, how do we prevent postpartum hemorrhage? So remember, active management of third stage labor is very important because, like at this point, even you have to consider even administration of oxytocin, as I said before. That is very important, and you have to clamp and cut the cords early, and that is also very important. But the most important principle of management is prevention is good, but if it happens and if there is a significant loss of blood, like 1 to 2 liters, they have to consider blood transfusion. That is very, very key aspect. However, oxytocin can be used for prevention as well as for treatment. It is an effective first-line treatment for postpartum hemorrhage. Remember, oxytocin can actually it can actually constrict the blood vessels, and even it actually even prevent blood flow to the uterus. Okay, then this one is the most common. Then what doses of oxytocin can be used? 10 unit IM after delivery of the placenta. So immediately after delivery, we're supposed to give 10 units of oxytocin intramuscularly. But the major issue with oxytocin, it has actually a weak antidiuretic effect and causes retention. But it is not very, it is weak. It is not like antidiuretic hormone. It is not like antidiuretic hormone. It is very weak. So, but however, it is still can cause water retention, and it could be a problem when a patient is having underlying cardiac and renal problem. So what are the side effects of oxytocin? Most of the time, synthetic oxytocin does not affect the cardiovascular system, but as a result of like water retention, there is a possibility of hyponatremia and it can cause seizure. The neonatal seizure have been reported as a result of this condition. Then on the GI tract, nausea and vomiting can happen. I think you can exhaust the side effect in the pharmacology counterpart. Okay, then in case if the patient is not responding for oxytocin, the next treatment approaches is the second line therapy. We can use ergot class of alkaloids. Remember, ergot class of alkaloids they are a very potent constrictor of muscle and they actually even prevent bleeding. So what are the drugs we are having? We are having methyl ergonovin, yes, and also we also have any other ergometrin is also available. So remember, with this class of drugs, you have to give them intramuscularly. If you give them IV, unless the patient is having very severe emergency, it can increase the risk of hypertension as well as cardiovascular accident. We call it stroke. But the CVA is like the most common abbreviation used by the medics if they don't know the type of stroke. Yeah, they say cardiovascular accident, which is a stroke, but this is when they don't know which type of stroke until they get the CT scan result. So this one can be used, but they are a second line. But the major class of this problem, this class of drugs are they are a potent vasoconstrictor and they can cause hypertension. Not all even hypertension, by the way. Sometimes even they can limit blood flow to some part and ultimately causes increased risk of gangrene. That is the risk of ergot class of alkaloids. Then, apart from that, this class of alkaloids, they can cause what? They can cause nausea and vomiting because they do have a dopamine 2 effect. They can activate dopamine receptor, then they can actually even cause what? Cause nausea and vomiting. So, and generally, they are not commonly used class of drugs. So, in general, the most common modalities of pharmacological modalities in the postpartum hemorrhage is oxytocin, but we also have prostaglandin analogs. So, prostaglandin analogs, they are second line agents in treating postpartum hemorrhage. Remember, they can actually enhance contractility and causes vasoconstriction. So we do have several prostaglandin analogs. Carboprost is one example. Carboprost is one example, and we do have also misoprostol. So they are second line agents. So the major problem with prostaglandin class of drugs, they can cause secretory diarrhea. So diarrhea is the most common side effects and limit its use in postpartum hemorrhage. But if we don't have an option, maybe you have to use. So this is like the treatment dose of misoprostol, and the other one is normally the prevention dose of misoprostol that can be used after delivery of the placenta. Yes. So this is how we're managing this condition, and we're expecting possibility of diarrhea is very high with the use of prostaglandin analogs. Then lastly, how do we terminate pregnancy? So remember, termination of pregnancy is known as abortion. So it is defined as a spontaneous or induced termination of pregnancy before fetal viability. Sometimes there is a possibility of spontaneous abortion, but there is also a possibility of medically induced termination of pregnancy before fetal viability. So according to different regulations, remember abortion in Kenya is prohibited unless it is medically indicated. So if someone is actually having or like do abortion without any medical advice, they will be arrested. They will be charged. That is the law in Kenya too. And even in many other countries too, abortion is not is actually a crime. Huh? It's a crime unless it is medically indicated. But in case if the fetus is actually causing life-threatening condition to the mother, we are supposed to induce abortion medically. And most of the time, abortion should be indicated before the stage of fetal viability. So, depending on the literature, the duration usually varies, but generally, abortion is usually recommended in the first trimester of pregnancy before it reaches to the stage of fetal viability. So up to this period, up to 20 weeks of gestation, it is possible, but generally it is very easier to do abortion in the first trimester of pregnancy. Yes, like before they reach a stage of fetal viability. So there are different procedure. There is a surgical component. They dilate, then they cut the fetus into different pieces, like to evacuate from the uterus. That is one approach. We call it the surgical approach. We call it even the manual vacuum aspiration. So the manual vacuum aspiration means they do have, I forgot to include an image about this one, is like they dilate, they do have an apparatus to dilate the cervix, then they actually even cut into different pieces. So mostly it is indicated when the gestation is less than 12 weeks. In that case, it can actually efficient. Then medical abortion is using pharmacological modalities, and it is usually efficient up to 13 to 20 weeks of gestation. And what are we going to use? What pharmacological modalities can be used to terminate pregnancy? Mifepristone. I hope you recall about mifepristone. Mifepristone is antiprogestin that can also even block glucocorticoid receptor. This is one of the drugs that can be used in the treatment of Cushing syndrome. Okay, so remember, progesterone is very important for implantation. It can actually even thicken the innermost layer of the uterus, that is the myometrium, so that like the fetus can actually implant to the uterus. That is very important. So progesterone is a facilitator for implantation of the fetus to the uterus. So when you give mifepristone, what will happen? It blocks the action of progesterone, so that what will happen? It actually causes like detachment of the uterus from the detachment of the fetus from the uterus. Then after mifepristone, you give misoprostol. Misoprostol normally promotes contractility of the uterus. So this one prevents implantation, then the other one promotes contractility. So synergistically, they can actually cause what? They can cause what? Medical abortion. So what dose? Mostly 200 milligram orally on day one, then followed by, after like 24 to 48 hours later, like misoprostol, 800 microgram can be administered by this route of administration, buccal, sublingual, or maybe intravaginal. So this is the most widely accepted regimen in the first trimester of pregnancy. So this is the medical abortion, like the medical induced abortion method we can use. So in summary, those are the pharmacological modalities we are going to use to induce abortion. In the first trimester, we can use the combination. Even misoprostol alone can also be used. And also the anti-cancer drug methotrexate, which prevents like cellular division in the fetus, can also be used in the termination of pregnancy in combination with misoprostol and DTC. So this is all about liver. Any question? Now you are welcome. Now this is the time for question and answer. Any question? So did you learn something?
And with exclusive videos, practice questions, and flash.
Labor, also called parturition, describes the hard work of delivering a baby. It specifically refers to the process which starts with uterine contractions, which cause cervical changes, which allow the fetus to be delivered vaginally, and ends with the delivery of the placenta. Labor typically begins at some point when the fetus is considered full term, between 37 and 42 weeks gestation. In the third trimester, before labor starts, A woman might have a plug of mucus and blood fall out of the opening to the cervix, sometimes called the bloody show. Other times, the amniotic sac might rupture, sometimes called water breaking. Either of these can trigger the onset of labor and so-called true labor contractions. These guys have to be distinguished from the milder and ineffective false labor contractions, also called Braxton-Hicks contractions, or sometimes called practice contractions. Once they start, true labor contractions progress in frequency, duration, and intensity, and they can feel like waves that build up to a peak intensity and then gradually decrease. The contractions pull on the thick tissues of the cervix, causing it to efface or get thinner, and also dilate or open up. So then, the fetus can leave the uterus and enter the world. From the moment true contractions begin to the baby's delivery usually takes about 12 to 18 hours for a first-time pregnancy, and about half that time for subsequent pregnancies. Although, as any mother knows, this time can vary a lot. Even though labor is a continuous process, it can be broken down into 3 stages. Additionally, this first stage is subdivided into 2 phases. The first phase is the early phase or latent phase, and usually lasts up to 20 hours, or until the cervix dilates to 6 centimeters. At first, there are irregular contractions that occur every 5 to 30 minutes and last about 30 seconds each, causing the cervix to dilate from 0 centimeters to about 3 centimeters, and efface from about 0% to 30%. Then, regular contractions follow. They happen every 3 to 5 minutes and last about a minute or more. And this causes the cervix to dilate from 3 centimeters to about 6 centimeters and efface up to about 80%. This marks the beginning of the active phase of labor, during which the cervix dilates from 6 to 10 centimeters and effaces to 100%. Contractions are very intense, lasting between 60 to 90 seconds each, with only 30 seconds to 2 minutes of rest in between, so sometimes they can even overlap a bit, with one contraction beginning before the previous one is done. Also, the amniotic sac often ruptures at this point if it hasn't already. Now that the cervix is fully dilated, we enter the second stage of labor, and this can be thought of as the pushing stage. During this stage, the critical thing is for the baby, and in particular the baby's head, to navigate through the maternal pelvis, and this depends on the 3 P's: power, passenger, and passage. Power refers to the forceful uterine contractions. Passenger refers to the fetus, and passage refers to the route that the fetus has to travel through the bony pelvis. In fact, the relationship between the baby's head and the bony pelvis is so critical that human babies have evolved with unfused skulls, just so their head can be as large as possible and still successfully and safely make that passage through the pelvis into the world. Now, there are a few factors that determine how easy this passage is for the fetus. First is fetal size. The critical factor here is the size of the fetal head. Also, there's fetal attitude, which refers to the way that the fetal body is flexed, not its personality. When labor starts, the fetus is normally fully flexed, which means the chin is on the chest, and they have a rounded back with flexed arms and legs. In this position, the smallest diameter, which is referred to as a suboccipitobregmatic diameter, presents at the pelvic inlet. Larger fetuses, and those that aren't completely flexed, have more difficulty making it through the passage. Next, there's fetal lie, which describes how the fetus is positioned in the uterus. A longitudinal fetal lie is ideal, where the long axis of the fetus, which is its spine, lies along the maternal long axis, the mom's spine. The fetus can also be transverse, though, where the fetal spine is perpendicular to mom's spine, or it can be oblique, where it's slightly at an angle, and these 2 positions can impede the progression of labor. Finally, there's fetal presentation, which refers to the first fetal part, called the presenting part, to descend into the pelvic inlet. Cephalic, or head first, is the first type, and furthermore, the most common and optimal presentation for easy delivery is a type of cephalic presentation called vertex, which includes complete flexion of the head as well. Also, there's breech presentation, which is head up, so the bottom, feet, or knees present first, as well as shoulder, where the shoulders present first. To make it through the passage, the fetus makes several positional changes, which are called cardinal movements or mechanisms of labor. Initially, there's descent, which is a downward movement of the fetus into the pelvic inlet. The degree of descent is called the fetal station, which is described in terms of the relationship of the presenting part to mom's ischial spines. The fetus moves from the pelvic inlet, which is at about -5 station, down to the ischial spines, which is station 0, and this position is called engagement. Then there's flexion, where the fetal chin presses against its chest as its head meets resistance from the pelvic floor. Next, there's internal rotation, where the fetal shoulders internally rotate by 45 degrees so that the widest part of the shoulders are in line with the widest part of the pelvic inlet. After the fetal head passes under the symphysis pubis, which is at about +4 station, there's extension, which is where the fetal head will change from flexion to extension, and then they move to about +5 station and emerge from the vagina. After the delivery of the head, there's restitution, where the head externally rotates so that the shoulders can pass through the pelvic outlet and under the symphysis pubis. And finally, there's expulsion, where the anterior shoulder slips under the symphysis pubis, followed by the posterior shoulder, and then finally followed by the rest of the body. This marks the end of the second stage of labor. The third stage of labor occurs after the baby has been delivered and involves delivery of the placenta. After the baby is delivered, the uterus contracts firmly and the placenta begins to separate from the uterine wall. It's then carefully removed to ensure that there are no placental remnants left in the uterus. Sometimes, several hours after delivery is called the fourth stage, because there are major physiologic changes like adaptation to the blood loss and the start of uterine involution, where the uterus begins returning to its pre-pregnant stage. Alright, as a quick recap, labor is composed of 3 stages. The first stage starts with true labor contractions and ends when the cervix is completely effaced and dilated. The second stage is the pushing stage, which ends with the birth of the baby. The third stage ends with delivery of the placenta.
Thanks for watching.
Okay, so this is all about labor. I think you just give much emphasis about the pharmacological aspect. That is the most important thing we need to know about it. So if you do have still further question, you're welcome.